Hello, everyone, and welcome back to Endo Bites. I'm Kate Glasenapp, and I'm pleased to be joining you today as guest hosts for this special Bite in Time bonus episode for our short format series focused on hot topics in endocrinology. I'm a nurse practitioner, assistant professor of medicine, and co-director of our medical weight loss program here at Froedtert and the Medical College of Wisconsin. In my clinical work, I help patients navigate obesity treatment options, which makes today's topic especially timely. So we'll discuss oral Wegovy, and this is the first FDA-approved GLP-1 receptor agonist pill for chronic weight management. What is it? How does it work? And what should clinicians realistically know as it enters practice? So to help us guide us through the science and the clinical implications, I'm joined by Dr. Srividya Kidambi, professor of medicine, chief of division of endocrinology and molecular medicine, and the co-director of the medical weight loss program of Froedtert and the Medical College of Wisconsin. Dr. Kidambi, thank you for joining us for this Bite in Time episode.
Thank you. I'm really excited about this. It's a new kid on the block, so very happy to discuss this.
So a lot to know and a lot to be excited about. So just before we focus on oral semaglutide, which is actually Wegovy, can you just give us maybe a quick overview of where we are with the medications for obesity?
Yeah, so, it has been a really exciting time over the past 5-10 years as newer and newer medications come into the market. As many of our listeners know, there were oral medications for weight loss for a number of years, some hits and some failures, but majority of them really produced only about maybe 5 to 7% of weight loss. Up until 2021, when injectable semaglutide entered the market as injectable Wegovy. Now, these original oral medications either worked by decreasing the nutrient absorption, particularly fat absorption, which is the old orlistat. And then we also have a drug called Contrave, which is a combination of bupropion with naltrexone, which affects neurotransmitters and works on appetite suppression. We also have very, very old phentermine, which again works through neurotransmitters by decreasing the appetite. So when the injectables came, they really changed the landscape of the medications. So the injectable weight loss drugs, which is semaglutide and tirzepatide, these are agonists of GI hormones, GLP-1 and GIP, and they now started producing weight loss in double digits, as opposed to what we had before, about 5 to 7% weight loss. So they changed the really landscape, and now oral Wegovy, oral semaglutide, is a same drug but in a different formulation. So that's exciting to have more and more options.
So how is this new kid on the block? How is it different than oral medications that we've had before?
So again, as I said, those were neurotransmitter or blocking the absorption. So the oral semaglutide is just semaglutide that we take as injection plus a compound called SNAC, which facilitates its absorption. So I'm going to talk about absorption a little bit later. So just seeing how these GLP-1/GIP-1 agonists work. So they work directly on the appetite center. So they improve satiety. So people feel satisfied with lower amounts of food. So that's the primary mode of action. But early on, there may also be decrease in gastric absorption time. Gastric emptying time. So the food stays longer in the stomach, so giving the sense of feeling full. So the actual mode of action with oral or injectable GLP-1 agonists is the same. It's just the difference in how it is absorbed and things like that.
And so in the past, the GLP-1s we have not been able to produce them in a way that it would be effective orally. It has not been done. Yeah. So what's different now?
Yeah, so as many of our audience may know that semaglutide and tirzepatide, these are peptides, so they're small proteins. So as you know, that our stomach and GI tract is meant for digesting protein. So when we eat meat, it needs to get digested. So we have a number of mechanisms. including gastric acid, which denatures the protein, and so it can be absorbed. And then we have a lot of peptidases, trypsin, chymotrypsin, and pepsin, which are produced both within the, in the gastrointestinal tract, and pancreas releases these into the GI tract, so they can all be absorbed. So if you gave any protein as a pill, it would get destroyed. It wouldn't be absorbed, similar to insulin, right? We don't have oral insulin. We have been injecting it, so that's how this came. Now, what the difference is that the oral semaglutide is a combination of semaglutide with a molecule called SNAC. Now, the SNAC is, so the oral semaglutide comes with its own personal technology to absorb it. So this particular compound, what it does is that as soon as it's taken in, it's dissolved by the gastric juices and increases the stomach pH. Stomach is always with an acid environment. So right around the semaglutide, this will create an environment where the acid is kind of neutralized, so it brings it to neutral pH. So now it will prevent the semaglutide from being denatured, or it's not, so now the semaglutide molecule is available. There are also some other ways that it actually preserves the fluidity of stomach membrane. So the stomach membrane can actually absorb this drug. So it is extremely important for the drug to be really in close contact with the stomach epithelial lining. So it is through the cell, it just passively diffuses. There are no receptors, there is no channels, no pipelines or anything like that. So that just gets passively absorbed into the gastric epithelial cells and from there into the circulation. There is some thought that SNAC may also improve lymphatic absorption, but that's not been what semaglutide is relying mainly on. But it's really passive diffusion through gastric epithelial cells via the microenvironment that is created by the SNAC. So it is extremely important mechanism for its absorption.
So it sounds like that is at least part of what any clinician prescribing this needs to understand. And then there's probably some issues too that patients need to understand.
Yes. So as I mentioned, the drug needs to be in close proximity to the gastric epithelial cells. So now that's why there are so many restrictions on how it should be taken. So it should be taken first thing in the morning on an empty stomach. That is because the absorption of oral semaglutide is only less than about 5%, maybe even 3 to 4%, as opposed to injectable semaglutide has an absorption of almost, the bioavailability is 99%. So it's very not absorbed as much. So that's why all these restrictions are there. So, and if you have another drug or food in the stomach, then it will prevent the drug to be coming in contact with the stomach epithelial cells. It may form a barrier, so it doesn't. So that's why you cannot have anything else in your stomach. The other thing is that the absorption really happens in the stomach, not in the small intestine. So you have to take it with only 4 ounces or less of water. Plain water, nothing else. The reason is that if you give too much water, then it might actually literally push this drug through into a small intestine, right? Because water can flow through. So we don't want that. Plus, too much water may also form a barrier film between the drug and the stomach lining. So it's very important that wake up in the morning, first thing in the morning, fasting, 4 ounces or less of water, and not eat or drink anything for about 30 minutes. Now, the absorption, whatever absorption needs to happen of this drug, because as I mentioned, it's so small amount that gets absorbed, the peak levels are done within 30 minutes. So it's really a fast process. So it's not like, so the studies have shown that if the smaller the amount of water that you take, 4 ounces or less, and the longer you fast after, a little bit better absorption. So instead of 30 minutes, if you give it about maybe 45 minutes or 1 hour, the peak concentrations were better. So I think that may be something that has to be emphasized. So that may also account for some of the variability in effect that you would see with the injectable drugs.
And I'm hearing water, not coffee, not a sip of juice, it's water.
Water.
Okay.
Yep.
So oral Wegovy, is it going to replace our injectables?
So, I don't think any drug replaces anything else. It's really a right patient, right time. So as I think the amount of weight loss that was seen with oral Wegovy, that 25 milligram dose, is equivalent or somewhat equivalent. So 13.6% versus average of about 14 to 15% weight loss you saw with injectable semaglutide. So seems like, it works pretty well. So the only difference that I thought was interesting between the oral and injectable Wegovy, even though the average weight losses are similar, is the number of people achieving that 5%, 10%. So as you see, many of the trials now report what percentage of people achieve 5% weight loss or 10%, 15%. So while average weight losses were similar, there may be a little bit difference in terms of number of people achieving 5%. For example, with the injectable Wegovy, 86% achieved 5% or more weight loss, whereas with the oral Wegovy, 76%. And that number for 10% weight loss is about 69% with injectable Wegovy, whereas it's about 60% with oral Wegovy, and about 15% weight loss. Injectable Wegovy saw about 50%, somewhat similar, like about 15%. So, and injectable, so I think there may be some small differences. Again, there are some people who really will not take injections. There is a advantage of not needing to be stored in a refrigerator or things like that. So I wouldn't say it is going to replace. Both have their place as to who takes it and who doesn't. And interestingly, the discontinuation rates were actually similar in both. So somewhere between 6 to 7%, despite the rigorous schedule or the instructions on taking it, at least in the clinical trial, there were only about 6 to 7% that stopped the drug.
Okay.
Yeah.
So like any other drug, you're matching the option to the patient.
Yeah.
So there's been so much about cardiovascular benefits of semaglutide.
Yeah.
Does this transition then over to the oral formulation, or where are we at with that?
So, the injectable Wegovy, the SELECT trial really showed significant cardiovascular benefit, which is prevention of major adverse cardiovascular events. Now, this is a smaller trial than any of the injectable drugs have done, around 350 subjects or so. And they did not really do the hard cardiovascular endpoints. So what they did do is that they got all the parameters, waist circumference and blood pressure and lipids and stuff. So the surrogate markers for cardiovascular disease were good. So even though we don't have hard outcomes, there is no reason to believe that it wouldn't work similarly. Okay. But there were no hard outcomes in this trial.
Okay.
Yeah.
So as Wegovy enters our practice, anything else that you think we should know?
So I just wanted to make one comment on the doses. So it's about 1.5 milligrams, 4 milligram, 9 milligram, and 25 milligrams. It doesn't feel like it's very intuitive. So I think that sometimes people may feel it's difficult to remember, but the dose escalation is once a month. So you give 1.5 milligrams every day for about a month and then go to the next dose and next dose. So it takes about 4 months to escalate dose to 25 milligrams. According to the studies, the 25 milligram of oral Wegovy is equivalent to 2.4 milligrams of injectable Wegovy. So the reason those dose escalations occur like that is because of a lot of research behind the doses and what it would compare to injectable dosing and what the bioavailability is, what the circulating levels are. So, it's not a linear absorption pharmacokinetics, as you would see in injectable. It's a little bit different because of the oral way it gets absorbed and the levels are reached. So you may have to just remember these doses. And so we are excited about the new one entering our market. And we hope more oral drugs will come into picture.
Okay. Thank you very much, Dr. Kidambi, for walking us through this important and certainly rapidly evolving topic. So that does wrap up the Bite in Time bonus episode of Endo Bites. Thanks to our listeners for tuning in, and we'll see you next time.